Assalamualaikum, everyone. This is an overview of less invasive surfactant delivery. The reason this talk that it is doable thing and why we are thinking of that. That's the most important thing. So I will go through some of the background that why we think about that, why we are moving towards non-invasive or less invasive things. We'll discuss some RCTs, CPAP, implementation, long-term outcome. Okay, so everybody know about this study, trends in care practice morbidity and mortality from 1993 to 2012. It's published in 2015. And this is very important study. It shows many variables, antenatal steroids, NEC, and many others. But look at the bronchopulmonary dysplasia. It is at the same rate or increasing. So something is we are not doing right. That's why it is going up and up. So if we generalize the things, we come to know that avoiding limiting invasive ventilation is a desirable thing. Even when you cannot avoid the ventilation, it has its own side effect. So all forms of respiratory supports are necessary evils. Okay, but if you use it inappropriately, become unnecessary evils. तो if I ask you people कि भाई inappropriately का क्या मतलब हुआ? So can anybody tell me what is the correct pressure for the 30 weeker, 32 weeker, 34 या full term के लिए आप कितना? It's just a generalization कि भाई full term के लिए इतना pressure और इसके लिए इतना. We don't know the structure of the lung and the pathology in that lung, premature or full term or meconium aspiration lung, is so different that we don't know. So it's a very, very complicated thing. That's why it's better to avoid ventilation as much as. Not only that, even the non-invasive ventilation, CPAP, NIPPV, high flow, low flow, they have their own things, something, some kind of problems. For example, pneumothoraces, nasal traumas, bowel perforation is also reported. So should be thinking less invasive respiratory support of the neonate? Yes. So start with that we use CPAP only, and there are many big trials. For example, Coin trial support won with the surfactant, and these are most of those trials are using only CPAP, and they have a very good results. But as I told you that the Coin trial has a 9% pneumothoraces or severe IVH, 9% pneumothorax and severe IVH 9%, 7% support trial was 14% severe IVH. So they have some there on their own. But if you compare intubation, ventilation, excuse me, versus CPAP, it's all the studies combined together go in favor of CPAP. So there is a almost 12% decrease in the risk of death or the BPD, and it is not crosses the line of confidence interval of 1. So it is go in favor of CPAP. But what happened? That CPAP from birth without the surfactant, the chances of CPAP failure is there. And that's the problem again. So this is the incidence and the outcome of the okay. So अब इसमें प्रॉब्लम ये है कि जो सीपैप फेलियर है उसमें आप ये देखें कि वो भी काफी ज्यादा है कि अगर आप सर्फेक्टेंट नहीं दे रहे उन बच्चों में जिनमें प्रीमेच्योरिटी है या कोई लंग प्रॉब्लम है, तो आप ये देखें कि 19,000 बच्चे थे और 12,000 61% जो है उनमें से मैनेज हुए CPAP। जो बहुत छोटे बच्चे थे 25 से 28 हफ्ते, उनमें 43% फेलियर रेट है CPAP का, और 29 to 32 वीक्स में 21% फेलियर रेट। तो CPAP alone is good but not the best option। ठीक है, चले अब आप ये देखें कि नॉन इन्वेजिव स्ट्रेटजीज जो हैं उनका जो क्वालिटी ऑफ एविडेंस है, अगर आप ये देखें तो ये सब मॉडरेट टू वेरी लो है। ठीक है, तो हमें कुछ ऐसा करना चाहिए कि वी वर मोर देन श्योर कि आवर बेबी विल गेट बेनिफिट फॉर दैट। ठीक है, सो व्हाट, अच्छा क्रोनोलॉजिकल ऑर्डर में चलते हैं। तो 2007 में 2007 से लेके वी विल स्टार्ट। व्हाट दे डिसाइड के अर्ली सर्फेक्टेंट एडमिनिस्ट्रेशन विद ब्रीफ वेंटिलेशन। So what they did, they give the surfactant and extubate to CPAP. Okay. And what are the results of that? I will come back to that. There is a big randomized control trial जो 2009 में publish हुआ, almost 300 infants, 27 to 31 weeks, 50 to 60 minutes of age. तो उन्होंने दो उसमें डिवाइड किए ग्रुप्स में, एक में इंट्यूबेशन, हेलो, एक में इंट्यूबेशन, सर्फेक्टेंट, एक्सट्यूबेशन टू CPAP, और एक में सिर्फ CPAP अलोन। तो ये आप रिजल्ट देखें कि मैकेनिकल वेंटिलेशन, mechanical ventilation is reduced in the group which they use the surfactant. सिमिलरली अगर इस टेक्निक को जो इंश्योर कहलाती है, इंश्योर का मतलब IN से इंट्यूबेशन, SUR मीन सर्फेक्टेंट, और E एक्सट्यूबेट, कि आपने इंट्यूबेट किया बेबी को, सर्फेक्टेंट दिया और एक्सट्यूबेट कर दिया टू CPAP। नीड फॉर मैकेनिकल वेंटिलेशन, इसका आउटकम जब देखें तो इट इज इन फेवर ऑफ दैट टेक्निक इंश्योर। ठीक है ना, in one of the study which I showed you, others are not significant। तो ओवरऑल आप जब देखते हैं तो इंश्योर वर्सेस CPAP, द रिस्क फॉर डेथ और BPD एट 36 वीक्स ऑफ एज इज नॉट मच डिफरेंस। ठीक है ना, सिमिलर फाइंडिंग फॉर डेथ एंड ALE। लेकिन अगर आप नेजल CPAP के बजाय उसको नॉन इन्वेजिव पॉजिटिव प्रेशर वेंटिलेशन पे डालते हैं तो दिस इज गेटिंग बेटर रिजल्ट विद द सर्फेक्टेंट। सो इस पे आप देखें कि जो रेड लाइन है वो नेजल CPAP की है, जो ग्रीन लाइन है वो NIPPV की है। तो मैकेनिकल वेंटिलेशन एट 7 days ऑफ एज, इसमें बेटर है, लेस एक्सट्यूबेशन फेलियर, लेस 23, physiological BPD less, oxygen at 36 weeks SPMA less, dose is not that much difference। तो it depends कि CPAP पे डाल रहे हैं बच्चे को या NIPPV पे डाल रहे हैं आफ्टर गिविंग द सर्फेक्टेंट। अगर अभी तक का कंक्लूजन आप देखें तो व्हाट इज इट, नॉन इन्वेजिव सपोर्ट लाइक CPAP और NIPPV इज एट लीस्ट एज इफेक्टिव एज इन्वेजिव। इंश्योर इज नॉट कंसिस्टेंटली, यानी कि इंट्यूबेट किया, सर्फेक्टेंट दिया और एक्सट्यूबेट किया तो कंसिस्टेंटली रिजल्ट्स नहीं है कि वो CPAP से बेहतर है। लॉन्ग टर्म आउटकम्स आर नीडेड। दैट्स डेवलप द थ्योरी कि अगर हम इंट्यूबेट ही ना करें, सर्फेक्टेंट डिलीवर करें थ्रू some other means, because के इंश्योर टेक्निक जो है वो भी, उसमें भी फेलियर बहुत ज्यादा है। ठीक है, so the hypothesis is, would even less invasive surfactant administration to a spontaneously breathing neonate improve outcome further? देयर आर 4 मेथड्स कि आप बगैर इंट्यूबेट किए हुए सर्फेक्टेंट दे सकते हैं। इंट्रापार्टम फेरेंजियल एडमिनिस्ट्रेशन, देयर आर फ्यू स्टडीज कि भाई जैसी बच्चे का सर निकले उसमें आप फेरिंग्स में सर्फेक्टेंट दे दें, एंड देयर आर सम गुड रिजल्ट्स। एडमिनिस्ट्रेशन वाया द एलएमए, एलएमए आपने, सॉरी अबाउट दैट, एलएमए आपने उसमें पढ़ा होगा आपके पाल्स कोर्स में, या आपने देखा भी होगा कि एलएमए आपने डाला क्योंकि वो कोई भी उसको यूज कर सकता है, उसमें स्पेशल टेक्निक नहीं चाहिए होती फॉर इंट्यूबेशन, आपने उससे सर्फेक्टेंट दे दिया। फिर एरोसोलाइज सर्फेक्टेंट है जो अंडर इन्वेस्टिगेशन है और ऑलमोस्ट कंप्लीट हो चुका है। अगर ये आ गया तो इट्स लाइक ए नेबुलाइजर, जस्ट गिव जैसे आप एस्मा में नेबुलाइज करते हैं, ऐसे आपने बेबी को दे दिया, इट गोइंग टू बी रेवोल्यूशनराइज बट स्टिल अंडर इन्वेस्टिगेशन। तो ये ऊपर की 3 टेक्निक्स आई विल नॉट डिस्कस, आई विल डिस्कस व्हिच वी कैन डू थ्रू थिन कैथेटर एडमिनिस्ट्रेशन। So, what is the difference between Ensure versus Lisa, Mist और List? ये तकरीबन similar है। Less invasive surfactant administration, minimal invasive surfactant treatment और less invasive surfactant treatment. तो Ensure जो मैंने आपको बताया था कि intubation, surfactant और extubation. What is the difference between this one or these 3? तो नीड फॉर डायरेक्ट लेरेंजियोस्कोपी दोनों के लिए चाहिए, ठीक है। आप कोई भी कैथेटर वोकल कॉर्ड के बिलो डालेंगे तो यू नीड टू लेरेंजियोस्कोप। नीड फॉर पीपीवी, इंश्योर में यस, क्योंकि आप इंट्यूबेट कर रहे हैं, इसमें रिलायज ऑन स्पॉन्टेनियस ब्रीदिंग, दैट्स द मेन डिफरेंस। पॉजिटिव प्रेशर वेंटिलेशन इज नॉट गुड फॉर द बेबी। तो व्हाट हैपन कि अगर बच्चा अब स्पॉन्टेनियस ब्रेथ कर रहा है, आपने उसको सीपैप पे या एनआईपीपीवी पे, जो भी आपके पास अवेलेबल है, उस पे आपने डाल दिया, ठीक है, उस पे वो ब्रीथ कर रहा है, एंड यू हैव टू गिव द सर्फेक्टेंट। दैट्स द मेन डिफरेंस, क्योंकि अगर आप बहुत छोटा बच्चा है या कोई भी बच्चा है, उसमें 8 से 10 पफ भी देते हैं आप अपने अम्बू बैग से, इट कैन more than enough to injure his lung. So need for PPV is a big difference between these two techniques. अब ट्यूब, इसमें जाहिर है कि एंडोट्रेकियल ट्यूब चाहिए होती है, इसमें कोई भी थिन कैथेटर मैं अभी बताता हूँ, आप कुछ भी यूज कर सकते हैं, आई विल कम बैक टू दैट। सिक्योर एयरवे, इसमें ऑफ कोर्स क्योंकि ये इंट्यूबेटेड है, इसमें यू हैव टू बी केयरफुल कि सीक्रीशंस वगैरह सब जो है वो क्लियर हों। वोकल कॉर्ड पोजीशन, अब जाहिर है आपने जब इंट्यूबेट कर दिया तो इट इज एब्डक्टेड, और इसमें कैन बी अडक्टेड आल्सो। तो वोकल कॉर्ड मोबिलाइजेशन आल्सो गुड इन दिस टेक्निक। सेडेटिव्स, many people use, many people don't use, ठीक है, we only use sucrose और sucrose gel. Tolerability, it is well tolerable more than 30 weeks. अच्छा, ये जो टेक्निक है मिनिमल इन्वेजिव, ये स्मॉलर बेबीज में भी वेल टॉलरेबल है, ठीक है। तो लेट्स से 28 वीक 26 वीक कैन डू दैट। सर्फेक्टेंट काइनेटिक्स अगर आप देखें तो लंग एसोसिएशन ऑफ सर्फेक्टेंट इज लेस, एंड द डायनेमिक कंप्लायंस, व्हाट इज कंप्लायंस के चेंज इन वॉल्यूम डिवाइडेड बाय चेंज इन प्रेशर इज द कंप्लायंस ऑफ योर लंग। और डायनेमिक कंप्लायंस कहते हैं जब फ्लो के साथ, जो आप फ्लो दे रहे हैं उसके साथ व्हेन यू मेजर इट। So the better distribution and improve dynamic compliance in this technique. Okay, so these are the difference between these two techniques. अब लीजा टेक्निक जो है, इस कैन बी डन इन मैनी वेज, many people do in many ways, but we do with the laryngoscope with no forceps, ठीक है, डायरेक्ट laryngoscope से डाल के आप उसमें डाल दें। it all depend on you कि आप कैसे अपनी टेक्निक डेवलप करते हैं। कैथेटर, now that this catheter is available, ठीक है, in the market, either you can use this one. If you have a 5 to 8 size NG tube, you can use it. Umbilical arterial catheter, you can use it. The only thing is that you have to develop your technique and skills to do to pass this catheter, the thin catheter, through the vocal cords. It is a survey which happened in 5 European countries: Austria, Belgium, Poland, Spain, and UK. And they all prefer this catheter, which is called Lisa catheter. It is available in the market. असल में ये उन्होंने ही बनाया जिन्होंने क्यूरोसर्फ बनाया. It is very cheap and available very easily. So this is the initial introduction. Now come to the evidence. कि what are the evidence? ठीक है. तो ट्रायल्स का जब आप देखते हैं स्टैटिस्टिक्स की और जब देखते हैं पिरामिड्स, तो सबसे ऊपर जो होते हैं वो सिस्टमिक रिव्यूज of randomized controlled trials. But we start with the non-randomized trials. So these are the observational studies by Dr. Angela Krebs from Germany from 2007, 8, 10, 11, 11, 12. So these are the non-randomized trials, okay? And they found some benefit of this initially, which lead to do the randomized control trials. These are the major published randomized control trials. AMV का मतलब है avoidance of mechanical ventilation, take care is a take care technique. NINSAP is a technique from the Germany, this is from Iran, and then it is from China. Let's see the outcome. Initially, 2015, the first study published from the China, and no difference. They couldn't find any difference and any advantage of that. That's fine. That's okay. Then from the trial in 2013 from the Turkey, they found it out that rate of mechanical ventilation in first 72 hours of life and BPT lower in the thin catheter group. TCA means thin catheter group. Similar from the other 3 centers from Iran, mortality lower in the TCA and they couldn't find difference in the BPT. Then the thin catheter trials in 2015, again, they found it out. The mechanical ventilator rate is lower in the thin catheter group. But the major trial are these one. जो मैंने पहले आपको बताया कि avoiding mechanical ventilation trial, 12 hospitals in Germany, they use the poractant alpha through the thin catheter. And what they found it out, a lower rate of intubation at 2-3 days of life, intubation, and no difference in mortality and pneumothorax or the BPT, but the intubation rate is lower. CRIP trial, which is NINSAP, non-intubated surfactant application, ठीक है, और ये 13 hospitals in Germany, so it's a big trial, and these are very small babies, 23 to 26 weeks. Reduction in absolute risk of survival without BPD and pneumothorax in the thin catheter group with the selective intubation group. Then in the Canada 2017 3 hospital trial also find it out absolute risk reduction in the need for mechanical ventilation. So the evidence are concrete and heavy in favor of thin catheter administration. This is a very interesting trial published in 2017 by Isayama in the JAMA. He compared with mechanical ventilation, Lisa has a lower rate of primary outcome and BPD. So Lisa technique उसने compare की mechanical ventilation से and they found it out better. Then he compared Lisa with the CPAP and he found it out that the Lisa is better in the other outcomes like air leak also. And what he did, he put the ranking probability of his strategies. So जिनको statistics से इतना पता नहीं है या वो familiar नहीं है, उनके लिए it's a very easy to understand. So I will show you now. तो एक outcome ये है death और chronic lung disease separately. ये ranking है कि कौन number 1 है, कौन number 2. यानी कि number 1 का मतलब ये है कि the chances of having mortality or the morbidity chronic lung disease is much less फिर number 2 पे. So look at that. Lisa is number 1. ठीक है. the probability of having no death and no chronic lung disease in LISA is very high. ठीक? नंबर 2 पे अगर आप if you can see is the NIPPV, number 3 is the INSURE technique, number 4 is CPAP. So if you compare LISA with the INSURE or CPAP, is better, even better than NIPPV. NIPPV means non-invasive positive pressure ventilation. ये आप ventilator के through without intubation through nasal prong देते हैं. So this is number 2. ठीक है. अगर दूसरा आउटकम देखें कि bronchopulmonary dysplasia और chronic lung disease alone, उसमें भी LISA is number 1. It means the probability is high to have no BPD with the LISA technique. So this is a very interesting and ranking probability strategies in this study. अब ओवरऑल इनको जमा करें तो दो मेटा एनालिसिस और सिस्टमिक रिव्यू विच इज द हाईएस्ट रेट ऑफ द एविडेंस, हाईएस्ट एविडेंस होता है इनका, वो 2016 में एक पब्लिश हुआ. इसमें आप देखें बीपीटी, all patient BPT in survivor, death or BPT, early CPAP, any mechanical ventilation or any mechanical ventilation reported. ये सारे is in favor of less invasive surfactant, except the reflex. I will come to that. ठीक है. इसी तरह की एक स्टडी पब्लिश हुई from Canada in 2017. Death or BPT at 36 weeks in favor of LISA. BPT at 36 weeks favor of LISA. Same with mechanical ventilation and mechanical ventilation at any time. Other pneumothorax, PTA, IVH, NEC, there is no difference. Of course, surfactant reflex is higher. मैं अभी उस पर आता हूँ, एक मिनट. लेकिन कुछ चीजें हैं. This is also very interesting, just published in April 1 year ago in 2019. कि if you do those things, it will help the success of this procedure. So for example, if surfactant dose, so if you use the surfactant dose less than 200 milligram per kg, the chances of your failure is high. ठीक है. So use at least 200 milligram per kg of surfactant dose. अगर एंटीनेटल स्टेरॉइड्स नहीं मिला है प्रीमेच्योर बेबी को, then the chances of this technique failure is high. So please tell your OBGYN, antenatal, steroids are very cheap. All those mothers should get antenatal steroid even up to 38 week of gestation. CRP अगर जो है वो more than 10 milligram है in less than 24 hours, the failure is high, but it is not statistically significant. Oxygen before mist is also is a problem, but not statistically significant. So ये दो तीन चीजों का if you ख्याल रख लें, especially the surfactant dose and antenatal steroid, the chances of your success is very high. अब दूसरी बात आती है कि कौन सी ऑक्सीजन, how much oxygen is the baby requiring कि you should do and you should give the surfactant. So this is a very good and easy study. They did two things: modeling cohort or validation cohort. Forget about the technicalities, but come to the conclusion. FiO2 30% in the second hour of life and radiographic severe RDS predicted nasal CPAP failures. देखें, प्रॉब्लम सारा ये है कि अगर नेजल CPAP फेल हो जाता है और उसके बाद आप इंट्यूबेट करते हैं और उसके बाद आप सर्फेक्टेंट देते हैं, the chances of that baby to be continue on ventilator is much higher, and he or she can become a very sick baby. You should predict that this baby can go into that direction and to act swiftly, यानी कि आप जल्दी से उसको सर्फेक्टेंट दे दें. तो any baby 30% से अगर 30% भी ऑक्सीजन रिक्वायरमेंट हो रही है उसकी in the second hour of the life, you should go and do that technique or that procedure to give the surfactant. And how we can do that, and what is our guidelines or the evidence on that. a very famous, published last year, middle of the last year, 2019, the European Consensus Guideline. If you don't have, please read it. If Vikram, agar aapke paas nahi hai, तो I will send it to you. This is a very comprehensive guidelines. All very famous authors are involved in that. What they recommend? CPAP से आप start करें. The level of evidence is very high, A1. Then babies RDS should be given rescue surfactant if it is 30% requiring or more. LISA is the preferred mode of surfactant delivery. So these are the consensus. ये तो मैंने related to this talk बताया, लेकिन पूरी guidelines हैं. You should read about it. Evidence हो गया, technique हो गई, किस तरह करना है हो गया. अब ये सवाल पैदा होता है कि इसको implement करना आसान है कि नहीं. So I took this study which is just published in July, and it is from the mid-sized country. Mid-size means is a small country, and the resources are not that very high. It's a medium country. And what they did कि इन्होंने स्पेशलिस्ट जो कि मिड लेवल पे थे अपने कैरियर के और रेसिडेंट जो कि ट्रेनिंग पे थे उनसे पूछा. And most of them say it is easy to do that. ठीक है. जब इन्होंने स्टार्ट किया Q1 2018 to Q1 2019, so 61 to go up to 76 in favor of easy. So they think that this is easy and can be doable after the proper education and proper training. So the LISA procedure does not appear to be technically difficult to master. Training combining theory with practical exercise is an efficient implementation strategy. तो एक तो ये. दूसरी, administration of the surfactant via the LISA technique in level 3 unit in Scotland. They also published the same things, that we have successfully introduced the LISA technique into their department and their results are better. और छोड़े आप इन बाहर की कंट्रीज को, आप में से किसको पता है कि ये पाकिस्तान से भी पब्लिश हुआ है? Maybe very few of this. Less invasive surfactant administration in preterm infant with respiratory distress syndrome, Journal of the College of Physician and Surgeon Pakistan, 2019, volume 29. ये आप उठाएं और ये देखें. ये हमारे फैसलाबाद या मुल्तान से हुआ है. They did also, and they did a very nice study. And they found it out that compared to ensure, the LISA method has been found to be more effective in managing preterm babies with RDS along with CPAP and thereby preventing complication due to intubation and mechanical ventilation. तो हमारे अपने मुल्क की स्टडी है ये, and I'm very proud of that. उन्होंने मुझसे पहले की बातें कांटेक्ट भी किया था, and we discussed a lot of things about that. In our healthcare system, they said with limited resources, this method can be promising and effective step, which is feasible, cost effective and safe. तो ये आप जरूर स्टडी पढ़ें and try to learn from that. Now, what is happening all over the world? कि कौन इसको यूज कर रहा है? ज्यादातर it is used in Europe, as it is invented in Europe. तो 2002 से देखें, all of a sudden is a jump. So most of the units, 51%, 52% using it, and 41% saying that it is a standard procedure for surfactant administration in the European countries. Same in the UK, 95% response rate, and the 62% use LISA. Same with the 30% oxygen or more. And so on and so forth, and they are using in a very small babies also. So it is from the Greeno group, which is the very famous neonatologist of the UK. The only problem is the USA. USA is still finding more evidence on that. This is the study of, I did the fellowship with her. I was senior, she was my junior, Shahana Parveen, and she published it in the Journal of Perinatology. Again, it is last year, 2019, and they look into this web-based survey that unlike several regions of the Europe, LISA is not widely used in the US. Still, they need more evidence as usual. Okay, so we go through the technique, we go through the evidence, we go through the implementation. It can be, but there are some troubleshooters, and we will discuss. So, agar bradycardia desaturation hai, many people use atropine before. Okay, don't use fentanyl or propofol. Just use sugar or sucrose or gel for pain management. Atropine you can use for bradycardia and desaturation. For apnea, we use caffeine before this technique. So caffeine we start very early in our babies. अगर पहली अटेम्प्ट में फेल हो जाए तो फिर आप उसको जाहिर है थोड़ा बेबी को सेडेट करें, so baby can be calmed down and then do it again. कितना इंसर्शन जाना है 1.5 centimeter for less than 27 week or 2 centimeter for all other. This is from the Melbourne Peter Davis group. He also was with us in the conference last weekend. Dislodgement अगर हो जाए तो check with easy cap carbon dioxide and you can see very easily. Cough, gagging, slow administrations, and this is I want to tell about the reflex. Okay, always go very slow 2 to 3 minutes to give through it. ठीक है, तो you can avoid the reflex. Again, use a small caliber catheters for the reflex, a small volume surfactant, Curosuf use करें, लेकिन we use with Servanta also, we have no problem, but yes, some reflex can happen. You can use the reverse Trendelenburg at 10 to 15 degree while doing this procedure. Okay, if a second dose required, you can use a higher dose. But improving LISA success, as I told you, NIPPV is much better as compared to the CPAP with the LISA procedures. Okay, so these are the troubleshooters. Now come to the outcomes. So these are the outcomes only we have from the one university, medical university from Vienna, Austria. 23 to 27 week gestational age, which is really a low birth weight babies or gestational age babies, and a lot of babies like 557 over the period of 2 years corrected age. And what they found it out, the statistically significant, the normal babies in the LISA group is higher as compared to the normal group in the control group, and the mortality is also lower, statistically significant lower as compared to the control non-LISA group. फिर उन्होंने 5 years उसको देखा outcome, and again there's a quite a good number, 236 babies, and what they found, 76% of those babies are normal. They do some like a Bailey scores. This is the cognition scores, and 90% of extremely premature infant have a favorable outcome at 5 years of age. And they said that not only increase survival but also increase survival with favorable neurodevelopment, which is we wanted. सिर्फ बच्चे को बचाना ही जरूरी नहीं है, लेकिन उसके साथ उसकी न्यूरो डेवलपमेंट और आगे चल के is like not a burden to the family. It should be a normal baby as other babies. So April 2020 mein, this is less invasive surfactant administration, best practice and unanswered questions. So what they are doing, that maintenance of spontaneous breathing with support by the LISA technique hold big promise, as we went through all this exercise. Patient comfort and lower complication rate are strong arguments to further investigate. As I said, that somebody using the sedation, somebody are not using the sedation, analgesia and sedation, if you are using it, but we use only the sucrose, and it is very well tolerated by the babies. studies on the long-term outcome after LISA are underway, because this is only one publication came out from Austria, Vienna, which I just showed. So this is the surfactant therapy, past, present, and future. So past में जब 1980s में we only have the synthetic surfactant. When I did my fellowship, we don't have the animal origin surfactant. We have Exosurf. During my fellowship, it comes first. Then prophylactic versus early. Then surfactant treatment in intubated. We are intubating everybody at that time. And then, as I said, animal-derived surfactant came. फिर 1990 से 2020 तक we go many techniques, intubation, then we come to the non-invasive ventilation, then we come to the insure technique, then insure versus LISA, as I showed you in our the evidences. But what is the future? Future most probably is the LISA plus non-invasive ventilation, okay, and the non-invasive surfactant treatment, for example, nebulization or atomization. तो अगर ये nebulizer और ये आ जाता है तो is a revolution in the field of neonatology if it is really work. The problem is that how big is the particle you should nebulize, which is affected the premature babies. That's why it is taking too much time. So that is going to be the future, as much as possible non-invasive. For the time being, this is my scheme. एंटीनेटल स्टेरॉयड हर किसी को है. आपके पास अगर CPAP अवेलेबल है तो CPAP यूज करें, NIPP भी अवेलेबल है तो वो यूज करें, प्लस अर्ली रेस्क्यू सर्फेक्टेंट. जो भी बच्चा 30% से ज्यादा ऑक्सीजन या 30% रिक्वायर कर रहा है, give by surfactant by this technique, or early caffeine. Caffeine is available in Pakistan, so there's no problem. So 1, 2, 3, 4. These 4 techniques, if you do, you will be better off. So yeah, Dr. Polin, who was again, he was my professor and mentor. He was with us in the last weekend conference also. He made this a sort of a scheme with Professor Wally Carlo, also from USA. Premature infant care in 2020. Expected prematurity, ask your antenatal, ask your OB/GYN to give antenatal steroids. दो में divide करें, infant breathing, infant not breathing. Not breathing, you don't have any choice, you have to give intubation, you give surfactant. अगर ब्रीथ कर रहा है तो उसको CPAP पे रखें. अगर CPAP पे स्टेबलाइज हो जाता है, दैट्स फाइन. और नहीं होता 30% से ज्यादा ऑक्सीजन या 30% ऑक्सीजन नीडेड within 2 hours, intubate, give surfactant or LISA. So both techniques are there, okay, but I showed you that intubation, giving surfactant, extubation as compared to LISA is more is not preferable. LISA is now preferable. उसके बाद and at the same time you give the caffeine, and अगर आपने intubate किया तो उसको extubate as soon as possible to CPAP. So this is the scheme. So to make it easy, this is our algorithm. Less than 26 weeks we are not talking about. उसकी वजह ये है कि they are very sick babies, and in our setting in Pakistan, it's not that feasible to do a great deal at this situation. Inshallah, आगे चल के उनको भी deal करेंगे. But for the time being, if the baby 26 or more than 26 up to 32 weeks in respiratory distress, try to have a CPAP, bubble CPAP or whatever. Oxygen requirement 30% या carbon dioxide more than 60 arterial or P5 या 6, then give the surfactant. As I told you, LISA, mist or insure, and start on CPAP. Agar baby cardiovascular compromise है, intubate, give surfactant, and try to extubate as soon as possible. अगर ऑक्सीजन रिक्वायरमेंट लेस देन 30% है, कार्बन डाइऑक्साइड लेस देन 60 और P5 है, कंटिन्यू विद योर CPAP और नॉन इन्वेजिव वेंटिलेशन विद close monitoring. Okay, so that's the thing. So the only thing you have to be um, थिंकफुल और केयरफुल इज इन्फेंट सिलेक्शन कि कौन सा बेबी आपको सिलेक्ट करना है फॉर दिस वन. प्री मेडिकेशन करनी है नहीं करनी, इट ऑल डिपेंड ऑन योर स्किल, डोज एंड प्रिपरेशन ऑफ द प्री मेडिकेशन and the safety issues. So it's all depend on your education, skill, and your willingness to do that. So in the summary, I'm finishing. I took too much time. The increasing of CPAP as initial respiratory therapy of preterm infant with RDS raises the questions whether surfactant application during CPAP is possible. So the answer is yes. आप CPAP लगा दें बेबी को और उसके साथ आप दे सकते हैं without intubation. The number of studies demonstrate the feasibility of surfactant application during CPAP or NIPPV via thin catheter lead to the hypothesis that the method may be beneficial. The answer is yes. There are concrete evidence in favor of that. Randomized control trial demonstrates an effect on the need for mechanical ventilation. Yes, to decrease, it all showed that it decreased the need for mechanical ventilation, which is going to be very cost effective. And reduction of neonatal complications seems possible. Yes. Positive effect on neurological and respiratory outcomes after LISA still need to be proved in large cohort. So अभी तक हमारे पास 2 साल का जो आउटकम है और 5 साल का जो आउटकम है वो सिर्फ 500 बेबीज और 293 बेबीज का है जो ओनली वन सेंटर फ्रॉम वियना ऑस्ट्रिया से हमें अवेलेबल है. तो वी नीड मोर on that, and still the studies are going on. So that's all. If you have any question, just